Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group where you can join the group, and this is very useful for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the Google Drive as well as the YouTube. These are the disclaimers and we are with phase 3, which is recorded pathology lectures. And today we have Pursue 3K, which is soft tissue and bone tumors. This is the third lecture in the series, which is being taken by Dr. Bhaskar Mitra, who's MBBS from Calcutta, MD, DNB pathology with gold medalist. He's a consultant histopathologist at the famous Tribedi and Diagnostic Laboratory, Kolkata, with multiple publications in national and international journals. He is a reviewer of various journals like International Journal of Surgical Case Report, British Journal of Medicine and Medical Research, Journal of Cancer and Tumor International, Journal of Surgical Technique Development, Journal of Applied Life Science International, International Journal of Dermatology. With this, I would request Dr. Bhaskar Mitra to start his lecture on approach to osteoid forming tumors of the bone. Very interesting topic. So over to you, Dr. Bhaskar Mitra. Thank you so much.
Good morning, everybody. I am Dr. Bhaskar Mitra. Today I am back with the bone tumors again. Now, we all know on my previous lecture I have repeatedly told that the bone tumor, to diagnose bone tumor, we need a team approach consisting of a radiologist, the information from the surgeon, and definitely by the pathologist. Pathologist who attempts to diagnose a bone tumor without clinical information and radiological finding is at distinct disadvantageous position. So never try to report any of the bone lesions without the radiological and the clinical findings. Now, bone tumors are mainly divided into the two things, primary bone tumors and the secondary bone tumors. Now, I will be discussing first the primary bone tumors. Now, bone tumors are grossly divided into the following things: bone forming tumors, cartilage forming tumors, miscellaneous tumors or miscellaneous origin tumors, hematopoietic origin tumors, and the fibrous tumors. Now, first, to diagnose the things, we have to divide all the tumors in the following category. Then we have to pick it up the exact right lesion as per the morphology, then proceed accordingly. Now, here we can see there is the bone forming areas. This is the cartilage forming tissue tumors. This is the small round cell tumors. This is the vascular tumors, and definitely again this is a very pleomorphic fibrous kind of tumors. Bone forming tumors, giant cell rich lesion, cartilaginous tumor, and the small round cell tumors. These are the basic things first we have to differentiate. On this basis, we will proceed to further evaluation of the bone. So this is the long list. I am not going to elaborate each and every one. It will be coming into the all the topics will be covered as per individual way. Now, this is the team approach. First, usually in cases of bone tumor cases, the biopsy or curating specimens comes. Then comes the resection specimens. The gross examination is most important, and then comes the microscopic, the key thing in the all diagnostic purpose. There are additional application of help of electron microscopy, immunohistochemistry, and the molecular testing. Some special stain may be helpful in some of the individual cases. Now, I'm now going on to the first topic or today's lecture, which is on the osteoid or the bone producing tumors or bone forming. Now, first, how the bone is formed or osteoid is formed. It comes from a multipotent stem cells which forms all the different types of mesenchymal cells in our body. These has got a unlimited renewal potential. Then comes the committed stem cells with the osteoprogenitor cells. These osteoprogenitor cells with the limited proliferations and the limited renewal capacity and unlimited proliferation, gradually they forms the osteoblast and the bone lining cells. Gradually, this osteoblast has a characteristics of producing the osteoid or the bone which was deposited into the matrix material, and gradually it got calcified. And this osteoblast entrapped within the bone it has formed, and it remains within a lacunae, then it is called the osteocyte. This is the osteoblast lying at the periphery of the bone formation, and here is the calcified bone formation is there, and in the center part the osteocytes are present. The osteoblasts are shown in a higher power magnification, showing a plasmacytoid appearance eccentrically placed nucleus. Now, what is the molecular genesis which are present in this bone formation? So this is the mesenchymal cells, it is the primitive cells. There comes after that there is a formation of skeletal precursor cells which express SOX9 and RUNX2 simultaneously. Then comes the transcription factor Osterix or SP7 on the early effect on the early osteoprogenitor cells, which are committed cells. Gradually that becomes committed progenitor cells. Now the early osteoprogenitor cells can even give rise to the chondroid cells. Now with the effect of the SADB2 and RUNX2, the committed stem cells becomes immature osteoblast. In between there is a molecular transcription factor FRA1, they forms the matrix production. In the later phase of this step, there is a SADB2 with the help of RUNX2. They form the immature osteoblast, they form the mature osteoblast, which gradually produce osteocalcin, which helps in the remodeling of the bone. So there is an important role of SADB2 in the osteogenic performance here. This is the schematic picture. Now from the same osteogenic progenitor cells, there may be skeletal progenitor cells, there may be development of the chondroid cells. This is osteoid cells which I have described in a short way, and this is the chondroid elements which will be formed from this skeletal precursor. Now coming to the bone formation, after that we are now concentrating on the bone forming tumors. Now first comes both the benign and the malignant tumors are there, starting with osteoma, and the list ends with osteosarcoma. This is the long list of bone tumors which produce the bone forming or osteoid forming tumors. The benign counterpart, there are osteoma, osteoid osteoma, osteoblastoma. In the malignant there is primary and the secondary osteosarcoma. Usually all have the higher age group, but in the osteoma this has got 10 to 20. Secondary osteosarcoma definitely is a disease of the older age group. Now first into the benign lesion is the osteoma or ivory exostosis. This is a rare bone tumor, appears as a localized thickening on the outer and the inner surface of the compact bone. Osteoma actually is a benign lesions of the bone that many cases represent a developmental aberration or a reactive growth rather than a true neoplasm. Usually occurs in the middle-aged adults, usually solitary, but if it's multiple, may be associated with Gardner syndrome. They mainly arises from the skull and the facial bones. It has got a bossylated appearance with the presence of round to oval sessile tumors that projects from the subperiosteal or endosteal surface. This is the osteoma showing bulk or progression into the softer part of the tissue. Again, there is effective demonstration of a bulge or protrusion of the bone on the outer surface of the table without any cortical invasion. Histologically, they are composed of dense compact bone or cortical bone arranged in a trabecular pattern with a distinct margin from the other soft tissue. Here we can see this is the case of osteoma showing the almost like a normal bone haphazard arrangement of the Haversian system with the presence of small osteocytes, and this is a well demarcated lesion and well formed nodular lesions. They do not show permeation into the surrounding tissue. The differential comes with this is the parosteal osteosarcoma. Usually osteoma has got a long history, absence of pain, and the smooth outline will dispel these suspicions. Sometimes some foreign body material may be confusingly told as osteoma. Then comes the osteoid osteoma. Osteoid osteoma is again relatively commoner lesion, 10% of the all benign bone lesion. It has got a characteristic nidus or center part of the lesion, and this nidus is less than 1.5 centimeter in diameter. Classically, the patient presents with the persistent pain which usually worsens at the night and usually goes away with the presence of non-steroidal anti-inflammatory drug. Now, according to the position, it can be medullary osteostoma with a sclerotic margin, or it can be a cortical sclerotic thing. This is the nidus. Usually this nidus is a small, less than 1.5 centimeter. Now, how the nidus looks like in the radiology, it shows the typical radiolucency at the center part of the bone, and this is area of the nidus. This is the whole mount slide which showing the exact location of the nidus. This is the nidus. The central part of the nidus is a sclerotic one surrounded by a fibrovascular tissue, connective tissue with the presence of different levels of osteoblast among it, and it has got a less scleroticity than the center part of the lesions. Again, this is the nidus. There is a haphazard production of the osteoid with a fibrovascular stromal tissue in between this. There may be presence of giant cells within this osteoclastic giant cell in these lesions. This is again histological feature characteristic of a nidus containing sheets of pink staining osteoid in a fibrovascular stroma. This is the nidus in operation table how it looks like. Now the differential comes the osteoblastoma. Osteo has got a nidus, but this nidus is a bit larger nidus. They has got a linear radiolucency perpendicular to that an angle of the cortex. The Brody's abscess or the bone abscess maybe sometimes comes in the differential diagnosis of osteoid osteoma, where there is a radiolucency with a sclerotic rim associated with the spondylpentine or the linear. This is the bone islands may be sometimes mistakenly confused as a nidus. It is a sclerotic bone lesions within the bone appearance. There may be intracortical osteosarcoma. Usually it has got a central fluffy densities and the cortex thickened and bulges with this. The osteoid osteoma patient in the long-term complication, they develop radicular irritation, psychic problems, and there may be entrapment neuropathy among this. Usually the osteoblastoma are located in the spine region, and there may be more cellular and omnious part. Symptoms worse at night. Again, it is relieved by NSAIDs. Now osteoblastoma, here the picture showing a good well circumscribed lesion here, and this is the picture showing the nidus. There is a haphazard arrangement of the osteoid with the presence of this fibroblastic stroma in between this area. This is the aggressive osteoblastoma where the radiology looks a bit worrying, where there may be irregular action and there may be periosteal new bone formation. This is again the periosteal osteogenic osteoma showing juxtacortical lesion in the mandible. There is classical appearance of the needle with the more size. This is the osteoblastoma pattern of osteoid deposition. There is a irregularly or haphazardly arranged bony trabeculae with a woven bone surrounded by plump osteoblastic cells. And there is a proliferation of the capillaries in between areas. Again, this is a proliferated vascular lesion with a haphazardly arranged osteoid, but there is now comes the atypical cells. There is a atypical osteoblastoma or which shows a pseudosarcomatous changes. It shows a haphazardly oriented trabeculae of bone with a hypercellular stroma with having atypia. This atypia is a kind of degenerative type atypia. There is and there is no significant mitosis, but the cells look very worrying or shows a pseudosarcomatous appearance. Now, the differential come is the aneurysmal bone cells, most common in this location. Osteosarcoma itself is come from the differential diagnosis. Now coming to the malignant thing, osteosarcoma is the only diagnostic malignant tumor of the bone. Normally, there is a defect in the molecular mechanism, there is a defect in the growth regulatory effect or depress in the tumor suppressor gene which may be altered or the lost. There may be alteration or mutation in the transformation activity. There may be few two genes translocation result in new hybrid gene which exhibit a strong activity as a transforming factor. These are the following molecular things which are responsible for development of this osteosarcoma, particularly the mutation in the retinoblastoma and TP53. There is a deletion of the CDKN2A molecule locus which associated with poor survival. Now, according to the location of this tumor, the osteosarcomas can be divided into intermedullary or the surface one. As per development de novo or from a previously disease, it can be primary or secondary. So this is the whole classification of the osteosarcoma showing different type of appearance like osteoblastic, chondroblastic, fibroblastic. This is the radiological picture showing a mixed sclerotic lytic lesions and with a periosteal reaction. This is a mass that has invaded the cortex of the bony cortex. In the slide we can see there is a normal bony trabeculae. In between there is the neoplastic cells which are infiltrating. Now again this picture clearly shows there is a abundant irregularly shaped osteoid deposited with the presence of this anaplastic osteosarcoma. Again there is a variation in the osteoid and bone formation pattern. These are the lacy strong osteoid which we can see in the normal conventional way. There may be associated fibroblastic osteosarcoma where we can see the proliferation of atypical spindle cells among the lesions. Now comes the pleomorphic sarcomatoid type of osteosarcoma where we can see the large bizarre shaped pleomorphic cells is in the tumor, and there is lace-like pattern of osteoid deposition and there is anaplastic tumor cells. There may be broad thick bundles of collagen. This is again anaplastic tumor cells with an epithelioid morphology, and that is the epithelioid osteogenic sarcoma. There is a coarse deposition of the osteoid separating the groups of malignant cells from the main stem. It can be beneficial. Now osteoid production and mineralization and along with the epithelioid features we can see in the left side of the case, and the right side there is a staghorn type of blood vessels there that is called hemangiopericytomatous like appearance. Now, chondroblastic osteosarcoma, it shows a chondroblastic differentiation. Suppose in cases of, as we see the ontogeny of these bone forming tumors, the early progenitors usually they have got all the features of both the bone forming and the cartilage forming. Gradually it gets separated and the cartilage part has been separated from the main stem. This is the chondroblastic osteosarcoma. So there is a de-differentiation from the bone formation to the formation of a new circuit. So this is another area. There may be small cell variant. Here the osteogenic sarcoma, the key factor is the osteoblast that can be present as a sheets and very small round cell figures. This is the epithelioid osteosarcoma showing the typical large epithelioid looking cells in the surrounding area. There is the myxoid osteosarcoma shows abundant myxoid production along with the different things. Pleomorphic atypical cells. There may be a numerous number of giant cells within the osteogenic sarcoma cases. That case, this is called giant cell rich osteosarcoma. There may be osteoblastoma like osteosarcoma, but usually they comes with the details. Now comes the telangiectatic osteosarcoma. The name suggests a ill-defined lytic permeative lesion in the distal metaphysis. Gross photomicrograph of this lesion shows an expansile hemorrhagic tumor. In the low power photomicrography shows a unilocular cyst architecture of the lesion. Instead, there is a high power of the septum with histiocytic like neoplastic cells showing nuclear atypia. Microscopic features of the telangiectasia osteosarcoma, there is a septations containing the pleomorphic neoplastic cells and the scattered multinucleated giant cells. Now, during the treatment process, there is a good role of chemotherapy in the osteogenic sarcoma cases. So, this osteogenic sarcoma cases after the treatment of chemotherapy are reassessed, taking a gross good amount of sections. This can be divided into the four stages, starting with the complete necrosis, no tumor cells, along with the none or minimal change in the body tumorous cells. Now altogether, when we determine the number of presenting or living cells, we exclude the dead cells. So this is the blue areas detected, the amount of dead cells we have rejected, and this can be done average estimation of these lesions. Now this is all about the intramedullary osteosarcomas. Now comes the surface osteosarcomas. The surface, it shows a bossylated appearance on the surface. It can be of parosteal type, which usually a bit of low grade, but it was covered with the cartilage. It was covered with this cartilaginous cells and everything. This is on the surface, but there is no periosteal elevation in cases of this uh, parosteal osteosarcoma. But in case of periosteal osteosarcoma, there is a elevation of this periosteum, and beneath it there is osteogenic sarcoma cases that working. Now, parosteal osteosarcoma, it is a anteroposterior radiograph shows a sclerotic lesion encircling both the tibia and the fibula, sagittally bisected resected specimen showing a dense fibrous bone surface mass encircling the tibia. The low power microscopy shows various patterns of tumor osteoid formation like interconnected and well developed bone trabeculae or fibroblastic stromal tissue is more important. Now, parosteal osteosarcoma has again a picture showing a sclerotic green on the outside. Gross photomicrograph consists of a bisected resected specimen showing a fleshy fibrous mass encircling the proximal humerus. The low power microscopy shows a well-defined coarse bony trabeculae lying in a. Now, this is the osteoid or bone forming lesions in a short nutshell. Here we can see, if we see a benign radiological features like a well circumscribed mass, no surface permeation or no invasion into the surrounding tissue, we consider first whether the lesion is in medullary location or in the cortical location. If it is a cortical location and the photomicrograph showing the typical mature bone, lamellar bone is there, we term this as a osteoma. Suppose if it is a medullary lesions and showing less than 1.5 centimeter nidus, this is again a osteoid with osteoblastic rim, and we can see the osteoids with the proper osteoblastic limen. We termed it as a osteoid osteoma. Now if there is a nidus and its nidus is more than 1.5 centimeter, it is a large nidus, and there we can see abundant of osteoid with osteoblastic rimming, then we term this as a osteoblastoma. Osteoblastoma sometimes shows abundant amount of epithelioid cells, which it is very difficult to separate it from the conventional osteogenic sarcoma. This is the spectrum of the disease. Starting in the on spectrum, there is osteoma, the most benign lesions. The midway there is osteoblastoma, and gradually it is the very worst and the malignant component of this tumor. This is a rough diagram which will help in the step-by-step differentiation. Starting with osteoid osteoma with the osteoblastoma, both occurring in the bones. They both have the nidus, but the osteoid osteoma nidus is less than 0.2 centimeter. If it's more than 2 centimeter, it is of osteoblastoma. There may be trabeculae, abundant fibrous, and the stromal reaction along with the proliferation of these fibroblastic and the capillary areas. In the osteoblastoma, we can see the central nidus with a sclerotic center surrounded by a marginal area. There is usually scanty stromal reaction. Now, osteoblastoma is aggressive, is second differential comes the osteoblastoma with the aggressive osteoblastoma. Aggressive osteoblastoma has got a higher cellularity, and the osteoblasts are 2 to 3 times larger than the conventional osteoblast. There is a wider and more irregular trabeculae bordered by this epithelioid molecule. Now comes the bones with the malignant radiological features. It can be medullary, it can be surface cortical part. There lies the medullary. If it is a lytic sclerotic lesion with a variable sarcometastoma, it is usually the conventional medullary osteogenic sarcomas. There may be sclerotic trabeculae with the cortical distortion, and the tumor osteoid hypocellular or atypical fibroblastic stoma is there. So this is a case of low grade osteogenic sarcoma. If it is a pure lytic lesion involving the medullary or the cortical expansion area, typical physiological features of ABC, but there is a abundant telangiectatic blood vascular sinusoids among the bone. If again the surface cortical area, there is radiodense bosselated mushroom-like lesions giving rise to string sign appearance in the radiology. Here these are the bony trabeculae, and it doesn't show any atypical features of Manic-Lane. Now remaining with these three things, the different remaining with these three things, there is a starting with there is a osteoma, that is the most benign thing. Then it was gradually there is osteogenic osteoid osteoma. Then comes the osteoblastomas with the aggressive osteoma sharing the same wall of the low grade osteogenic sarcomas. So for the bone forming tumors, we first have to determine whether it's a benign or it's a malignant radiology. Then according to the flow diagram, we will proceed according to whether the nidus is seen on the other things. So thank you everybody. I will be back again with the chondroblastic tissues, bone tumors with the cartilaginous differentiation or formation of the cartilaginous material. Thank you everybody.